Welcome to AETCM, the Emergency Medicine channel. Today we are going to discuss a case about a 22-year-old male residing in Madhya Pradesh came to a ER with history of fever for the past 4 days associated with altered sensorium. Shall we begin, sir?
Yes.
So on reaching our hospital, in initial 10-second assessment, he was conscious and oriented. Coming to the primary survey, in airway, it was appearing patent and there was no secretion, and spine was appearing normal. Breathing, air entry was bilaterally equal with respiratory rate of 18 per minute and saturation of 97 maintained in room air. Coming to the circulation, BP was 110/70 mmHg with pulse rate of 72 per minute and all peripheral pulses were palpable. In disability wise, GCS score was full with pupils bilaterally 2.5 mm reactive, equally reactive. Exposure wise, temperature was afebrile and GRBS was 140. Coming to the adjuncts to primary survey, we took a VBG. VBG was not showing any acid-base derangements.
What is the difference between VBG and ABG? Why we are taking VBG? What is the difference?
Oxygen saturation.
Saturation difference will be there. pH?
0.03 different.
pH there is no much difference. So except your saturation levels like O2 and CO2, rest all are almost same. So if you want to know the acid-base disorder other than respiratory cause and any other electrolytes like our ABG machine shows almost all electrolytes. For that all VBG is enough. Even in diabetic ketoacidosis, repeated samples you no need to prick P. Just take VBG and see whether there is a difference in the pH. That is very minimal. So that is very useful. Instead of pricking every time, this can be taken. But respiratory condition, we are not supposed to do it.
And further moving on, ECG was also not showing any abnormalities. And
why you are taking ECG in a patient who is having fever?
history of fever with altered sensorium. One will look for myocarditis and
What change you will get in myocarditis?
ST depression.
ST depression, TO inversion, tachycardia. Okay.
And other than that,
Pericarditis, what change you will see in ECG?
will like a ST depression, which will be.
What is a typical feature of pericarditis in ECG?
After the QRS, there will be a happy face pattern.
What is it? ST elevation with concavity upwards.
Upwards.
Okay. So that is, how do you differentiate that from myocardial infarction from what is the difference between?
Concavity will downwards in myocardial.
Concavity is downwards in myocardial infarction.
This will be
Other than
upwards.
that? So all leads are pericarditis. Some leads with reciprocal changes are in myocardial infarction. What is a reciprocal change? What is a reciprocal change?
ST elevation, there is reciprocal change.
Okay, if ST elevation in the anterior leads, ST depression in the inferior leads. Inferior leads, ST elevation, anterior leads, you get ST depression.
And further, we went ahead with the survey. Coming to the secondary survey, he was a 22-year-old male residing in Madhya Pradesh, and he was having history of fever, which was continuous high-grade fever, intermittently occurring for the last 3 to 4 days. And initially he had also loose stools with the non-productive cough also, and nasal congestion. Patient was initially started with symptomatic treatment in Madhya Pradesh itself, and as the fever was not subsiding, went to a nearby hospital and got admitted, wherein which the patient through 2 seizures, GTCS, and followed by altered sensorium, and he was agitated, and the bystanders were telling that he was like having an elated mood. And MRI was taken.
So if in that case, what all things you suspect? After seizures, he is having altered behavior, some joyness after enjoyment after seizure episode. What all things you suspect?
Meningitis.
Meningitis, why should he have joyness? Post seizure and joyness. They are telling that there we should always think about something else.
Substance abuse.
Substance abuse, especially tramadol. Tramadol is one drug which can produce withdrawal seizures. Okay, that is very common nowadays. We have to think all these things. I am not telling every patient is like that. Young patient coming with seizure, after that some other behavior pattern. One of the possibilities tramadol withdrawal, but here it is maybe due to fever. Okay. How do you know that it is GTCS? Somebody witnessed?
Witness seizure, sir.
Okay. How do you differentiate between seizure and syncope? Syncope is very common in fever. How do you know that it is seizure, it is syncope?
Postictal phase will be.
Postictal, what is that? Postictal confusion. Post loss of consciousness, confusion goes in favor of seizure. If that is not there, it can be syncope. That is very common in fever. Okay.
Then following with MRI was taken there. MRI was not showing any abnormalities. No leptomeningeal enhancements was noted. And further on evaluation, typhoid test was done and it was positive, and he was referred to a hospital.
What was positive there?
Typhoid test. Typhoid.
Okay.
And on reaching a hospital, his TCS was full score, and we went ahead with our further evaluation, including lab investigation, wherein which CRP was found to be 112 with SGOT-PT having mild elevation of 67 and 64, and the ALP was
in a patient with SGOT-PT elevation, when will you call it as significantly elevated?
3-fold rise, 2 to 3-fold rise.
What is significant elevation of SGOT-PT? Clinically, what is significant? If it is elevated, it is elevated. 3-fold elevation with symptoms, 5-fold elevation without symptoms. Both are significant. But in a patient who never had past history of SGOT-ST elevation, now you are seeing SGOT-PT elevation even in small units, that also can become significant. Okay.
And the ALP was 150.
Okay.
Other than that, total count was 4,000 with the platelet count of 1,77,000, and HB was 13.5. Urine routine was within normal limits. RFT was also within normal limits. Further, as he have already done with the MRI, we never went ahead with another survey, but we repeated the typhoid test. Typhoid IgM came out to be positive for us. And on further, we started him on antibiotics, ceftriaxone we started.
How do you diagnose typhoid?
Typhoid, we can send for...
First week, how do you diagnose? Second week, how do you diagnose? Third week. For us, it is first week and second week. How do you diagnose in first week?
We can send typhoid IgM after 5 days.
5 days, first few days, how do you diagnose?
We can send for antigen.
The problem is most of the time in second day, third day fever, when the patient come to emergency room, we send, doctors send all the investigations. IgM, lepto, IgM, dengue, IgM, typhoid, everything. Actually, it is not correct. First week, only if you want to send a test for typhoid, that is blood culture. Second week only, you should ask any antibody investigation. All antibodies are produced only after 5-6 days. So we are not supposed to ask any antibody test in the first week. In leptospirosis, what test you will do first week?
Initially, we can went ahead with the
leptospirosis. What is the first week?
The microscopy,
urinary dark field microscopy or PCR test,
PCR
like
can
we
be
told.
done.
Then dengue?
Dengue antigen, NS1 antigen.
NS1 antigen, okay. So antibodies will be positive only second. So you are not supposed to. So second week, what test you do?
Antibody test can be.
What is that antibody test we are asking?
Typhoid, flagell,
Vidal
O
test.
and H, Vidal test.
Vidal test. Vidal test, O and H is there. Which is significant?
H.
If H is not there, then it is O. Like
Now,
that.
is common in both paratyphoid and typhoid. So,
Which is significant? You tell me to make a diagnosis, which is more important, O titer or H titer? Huh? Both are important. It is odd titer. Odd titer is more important, and that itself initial high titer with rising values increase. So today I am doing, after 48 hours I am doing another test. If it is increasing, that is more significant. Okay, so odd titers are very important. H titers can be positive, and H titers are positive in previous infection, anamnestic reaction, all these things. So odd titer has to be elevated, and second, suppose you are doing a second test after 48 hours, it has to be increased. Then only you can make a diagnosis of typhoid. Okay. So we have done a vital test that shows high titers. Okay, then.
And further, he never threw in any more seizure episodes.
Okay. So when you get a seizure like that, that is a most important problem in emergency room. You are getting a fever, you are getting a seizure. What do you do?
So, fever can induce seizure. So
Fever can induce seizure only in children. Normally, fever will not produce seizure in adult. Fever will not produce, but the pathology behind fever can produce. Here, maybe typhoid encephalopathy might have produced the seizure. How do you manage it?
typhoid encephalopathy, steroids.
Any seizure in emergency room due to an infection, how do you manage? And somebody is having a seizure not because of infection, he may have a status epilepticus due to something else. Here, what do you do?
Benzodiazepine can be given.
Okay, benzodiazepine can be. Which benzodiazepine is ideal?
Midazolam.
Midazolam. What is the advantage of midazolam over?
Short acting.
So it's a short acting drug. You can give midazolam or lorazepam. Lorazepam IV or midazolam has to be given as infusion. Okay, short acting drug. It is ultra short acting drug. So you'll have to continue sometimes infusion. Should we give phenytoin in this type of patients?
Phenytoin can be given.
Yes or no?
Yes.
Yes or no? So before doing anything, you have to rule out the sugar value. Okay. All patients who is having any type of infectious fever, sometimes the seizure is due to hypoglycemia. So unless until you rule out hypoglycemia, you cannot you are missing the original diagnosis. So you have to rule out sugar. Then you can, suppose there is no hypoglycemia, hyperglycemia, then you have to start phenytoin, because there is a problem in the brain that can again produce seizures. Okay, unless until you treat it and correct it. Okay, treatment we'll discuss. Hyperglycemia, can it produce seizure?
Yes.
Both hypoglycemia and hyperglycemia can produce seizures. That is very important. So how do you manage this case now? We know that it is typhoid. Okay.
So
and he had seizure.
Suspecting typhoid encephalopathy, for the same we can start him on steroids.
What is a typical feature of typhoid encephalopathy?
Altered sensorium with memory loss, confusion.
Any typical finding? You recently finished a NEET exam, no? What is a typical finding? They pick the cloth like this. That is a typical finding. What is it? Muttering delirium. Okay. They try to pick up the cloth like that. Okay, that is a typical feature. We never see it because we treat the patient immediately. Okay. How do you manage? So here the patient is having seizure. We have to control the seizure, whatever it is. How do you manage this case?
And for preventing seizure, we can start with levetiracetam.
Why levetiracetam? Why not phenytoin?
Levetiracetam has very less adverse effect.
What adverse effect you are talking about?
LFT.
LFT. So phenytoin can sometimes produce hepatotoxicity. Here you are suspecting a fever, like altered liver enzymes. Then better to go for levetiracetam. What is the dose of levetiracetam in acute settings?
40 mg per kg. 40 to 60 mg per kg. 40 to 60 mg per kg.
Okay, 40 to 60 mg per kg. Loading doses. All drugs we should give a loading dose for seizure. Okay.
And for encephalopathy, we have to start with steroids.
What is the dose of steroids?
8 mg loading dose, TAD dose.
So this is one condition where you have to give high dose steroids in 3 times. Okay. Rest all conditions we give around 8 milligram once daily, 4 milligram once daily. Enteric encephalopathy, you have to give very high dose steroids. Okay, then.
Other than that, treatment for the typhoid, antibiotic should be started.
What antibiotic?
Here we can start with ceftriaxone.
Ceftriaxone. What is the dose?
Here as 1 gram will be fine. Meningitis dose can be given if
So
at all we are
in a
suspecting.
normal enteric fever who is having only fever and all, 1 gram BD or 2 gram OD will be sufficient. But any patient who is having enteric encephalopathy, you need to give a higher dose
High
like 2 gram BD, something like that. How long you have to give the treatment?
5 to 7 days.
5 to 7 days is enough. Suppose this patient is having severe abdominal pain, what do you do? Severe abdominal pain, what do you do?
We have to suspect perforation intestinal
What do you do?
X-ray
X-ray?
abdomen, erect to
Erect abdomen. What you will see in that?
air under diaphragm.
Air under diaphragm. Okay. What happens to the WBC count in enteric fever?
Leukocytosis and leukopenia can be.
Which is more common? Which is more common?
Leukopenia.
Leukopenia is more common. If the patient develops leukocytosis in a suspected enteric fever, what is your diagnosis?
Perforation.
Intestinal, what is it? Peritonitis and perforation. That is very common. What happens to the pulse rate in typhoid?
Relative bradycardia.
What is that?
When temperature increases, usually we'll expecting an increase in pulse rate.
That
heart
is
rate.
not there. Suppose the typhoid fever patient is having tachycardia. What is the finding? What is your diagnosis?
Myocarditis.
One is myocarditis. Then again there are also intestinal problem can produce tachycardia. That is peritonitis, perforation, all these things. Okay, what happened to the tongue in typhoid patient? Tongue. Cotted tongue. Skin, rose spots. So these are the common finding we never see, but tongue is a very classical finding. You can see in tongue. Okay. So what happened to this patient afterwards?
We started with the IV antibiotics along with the anti-seizure medications, and 3-hour EEG was also taken.
Okay.
EEG was not showing any abnormalities. Further, he had no any more seizure episodes. Patient is in our admission.
Why should we take an EEG in this patient?
History of seizure episodes.
History of seizure episodes are there, but we are not seeing anything. No? Why should we take? What is this non-convulsive seizure? In ICU, you tell non-convulsive seizure and you ask for EEG. You know what is that? Without knowing clinical diagnosis, we cannot send it for this one. What is non-convulsive seizure?
That we won't be able. We are not
seeing. Patient is unconscious. Patient is fully unconscious. We are not seeing any active motor movement. We are suspecting that this can be seizure. Only in that condition we have to take an EEG. Okay, here patient is fully conscious. He is talking. He cannot have a seizure at all. So only if the patient is developing another episode of seizure, or he go to an altered sensorium, or he is unconscious, then you are not able to tell whether it is a, what is that you told? Non-convulsive seizure. Okay. What is non-convulsive seizure? What is that non-convulsive seizure? When you go to ICU, you will see that type of patients. What is that non-convulsive seizure? What is seizure? What is epilepsy? What is convulsion? What is seizure? What is epilepsy?
Disorder.
What is convulsion?
Convulsion is the jerky hand.
Convulsion is the motor part of the seizure. What is seizure?
Seizure is
Abnormal hypersynchronized electrical activity from the brain. Last one is epilepsy. What is epilepsy?
syndrome of the
Continuously somebody is getting this seizure activity, you call it as epilepsy. Okay. So non-convulsive seizures can be seen in ICU. Patient who is admitted with encephalopathy, they will be unconscious in spite of your best treatment. They are not recovering. In that condition, to diagnose seizure activity, you have to do this test, EEG. Okay. Here it is not indicated. You should not do that. Should we continue anti-epileptic drugs here? Yes or no?
Yes.
You have to continue.
It's loaded and the patient started on it. Taper it off until.
Okay, should we continue? So normally in an epilepsy, like if you don't know what is the reason, you have to continue at least for 6 months. You have to continue minimum for 6 months. But here we know the reason, it is enteric encephalopathy, and we don't know what is the sugar status during that epilepsy. So we can probably stop it and watch the patient. Patient may not develop another episode. Okay, so when you are planning to discharge this patient, what advice you give to the patient? when are you planning to discharge the patient, what advice you give to the patient, which all category of patients you have to be very careful. First of all, you have to ask what is his job. What is his job?
Chef.
His job is chef. What is typhoid Mary? Huh? You know that, no? Typhoid Mary. Because chef is the most dangerous profession for typhoid. They can spread typhoid everywhere. So what you can do for that? After discharge, what all things you have to take care? What is chronic carrier state?
Having typhoid greater than 12 months following.
How do you diagnose it?
Check for titers. Stool
culture you have to do, because it can spread from the gallbladder for a long period. In that type of patients, you have to give quinolones prevention. Okay, so you have to follow up this patient. You have to advise the patient. He may have to take quinolones for a longer time if his stools containing typhoid bacteria positive. Okay, so we have to be very careful. He can spread typhoid like anything. Okay, anything else you want to add? You want to add anything? Nothing. Okay, thank you.